Let's start with the history. In 1985, Professor Dr. Slan described this technique. He worked in the cortesía group in Paris. They made a lot of iliac crest graft to maxillofacial surgery. In a massive implant failure, he decided to place an implant in the pterygoid process. When he checked that the implant was successfully integrated, he decided to describe this technique. From this situation, many doctors started to present their first result of the technique. These studies validate the success of the pterygoid implant with an average success rate of 92%. We have also carried out our own study with the Clinical Research Department of Zurich. It's a retrospective study of 8 years with 257 pterygoid implants, rendering a cumulative survival rate of 93.9. This data validates that the pterygoid implant is a successful technique in atrophic maxilla. In description to anatomic relation, we have a study with the Medical University of Valencia with Professor Soriano. We have carried out diverse anatomic research of the pterygomaxillar region to better understand it. We must locate the high-density area. This is due to the confluence of the pterygoid bone, the pyramidal process, and the maxillar tuberosity. In this high-density area is where we have to fix our implants. It's the same concept as all on 4. We must reach the high-quality bone. In the pterygomaxillary fossa, the maxillary artery emerges and gives 6 collateral branches. We have never encountered any bleeding problem, so the classical fear of bleeding shouldn't be any problem. In the past, I have the chance to listen the most technical doctors, and what they explained was that it was a very complex technique. They had bleeding risk, and only an expert are be able to do it. And if you punch the maxillary artery, the patient dies. Oh my God. I'm proud to say that this is not a complex technique. We have never encountered any bleeding problem, and most doctors are be able to do it. Many anatomies describe different types of relation with the sinus, with the teeth, and the bone of the maxilla. As a result of dealing more and more cases, we saw that we need something to predict the difficulty of his case. PARP concept is a classification to predict the anatomic risk in the pterygomaxillar region. PARP concept allows to individualize the risk of the clinic situation. All this allows to provide a success rate in atrophic maxilla. In function of the sinus invasion and the remaining bone obtained by ortho scanner, we have the PARP classification. We have 4 types. In PARP1, we have no sinus invasion. We find a remaining bone more than 30 millimeters. So, in function of the density bone, the surgeon will decide if it rises to the pterygoid process or not. These are the most favorable cases. In PARP2, we have minimal sinus invasion. The remaining bone is shortened between 10 to 30 millimeters. So the surgeon is limited to this length. These are their classical retromolar implants. In the PARP3, we have a moderate sinus invasion. The bone is between 5 to 99 millimeters. And in the root of the implant, we have bone, air, bone. So we must reach the pterygoid process. In the PRP4, we have a critical sinus invasion. The remaining bone is less than 5 millimeters. So in these critical situations, we can choose another techniques like sinus lift or zygoma. But however, if we decide to do it, we have to risk the pterygoid process. Now, I'm going to explain some example of PRP classification. In this ortho, we see that we have more than 70 millimeters. How we do the merger in the PRP concept? We start behind the second molar until we arrive to the high density area. In the scanner, we validate that we have more than 60 millimeters. So this is a clear PARP1. There are the most favorable cases. We have used 15 novel active implants. In this case, we see that we have 11 and 40 millimeters. In the scanner, we validate that we have a remaining bone between 10 to 30 millimeters. So it's a PARP2. We have used 11 and 50 novel active implants. Here, we have a more difficult case. We have remaining bone around 5 millimeters, so it's a PARP3. In the implants route, we have bone, air, bone. We have used 16 millimeters novel replace select tapered. I made this surgery 9 years ago. And the support is in the pterygoid process. And the patient is perfect, and I'm so very happy. If not, my nurse will have my head because she's her mother. Here, we can see a very difficult case. We have a remaining bone less than 5 millimeters, so it's a PAP4. We have used a 16 millimeters replace select tapered implants. I use pterygoid implants to avoid the cantilevers, and I prefer to do these techniques than only all-on-4. Which implant we use? We started with novel replace select tapered 10 years ago. After this, we have proved many types of implants. But nowadays, our choice is novel active. Why novel active? Because we have a self-drilling protocol. We can adjust the implant position during the placement. We have a primary stability, and the conical connection offer high mechanical strength. So it's why it's our choice. The advantage of tethered implant are better use of remaining bone, better bone implant contact, and better load distribution. Our prosthodontic protocol, we do always with CAD-CAM design, we do always the screw on multi-unit abutments, and the materials we use metal porcelain, titanium and acrylic, and zirconia. In immediate function, we do a screw on multi-units with light occlusion contact, no tissue conditioning, and we use acrylic materials. In the definitive works, we do always with CAD-CAM, screw multi-units, and we use metal porcelain for bridges, and titanium and acrylic and zirconia for the global rehabilitation. the more indications in your mind, the more cases you will solve. And now I'm going to show some clinical cases. Here we can see in the orthodontic scanner that we have a remaining bone between 10 to 30 millimeters. So it's a PARP2. We have used 11 and 50 novel active implants. And here we can see we have used metal porcelain crowns. And here's the result. Here we have a very difficult case. We have a remaining bone less than 5 millimeters, so it's a PARP4. We can see in the scanner we have to make a critical angulation to fix our implant. We use pterygoid implants to avoid the cantilever. In these atrophic bones, we prefer to use titanium and acrylic. We use the pterygoid implants to give more support to the zygoma implants. In this case, we have used zygoma implants and the pterygoid implants to avoid the cantilevers. In my opinion, this is an excellent result because before this surgery, she was very sad, and now she has a new life. For me, it's what this makes sense for me, when I can change the quality of life of people. And that's all when it makes sense, when somebody tells me that we have changed his life. And finally, I would like to make some final conclusion. As in the same way, in the sinus leaf, we had so many classifications in function of the remaining bone, we see that we have the same need in the pterygoid region. So, PRP concept is a guide to avoid the doctors to have unnecessary risk. And in the posterior atrophic maxilla, we have different techniques, short implants, title implants, zygomatic implants, pterygomaxillary implants. We must do the best for the patient, not for us. So, for example, if I have an easy sinus leaf and I have a PRP4 pterygomaxillar implant, I make sinus leaf. However, if I have a critical sinus leaf and I have a PRP1, I do a pterygoid implant. We must do the best for the patient, not for us, for the patient. In the last 10 years, PRP concept has allowed me to solve many complex techniques in an easy way. Thank you very much.